Good morning, everyone. My name is Cedric, and it's been a while since we last had our last CME. So today we'll be talking about complex regional pain syndrome, otherwise known as CRPS. So by definition, it is also known as a reflex sympathetic dystrophy. It is an idiopathic condition caused by an aberrant inflammatory response that lead to sustained sympathetic activity in a perpetuated reflex arc. So normally patient will come with extremity pain that is out of proportional. So by classification, there are two types of classification, namely the Langford and advanced stage of RSD and also International Association of Study for Pain classification. But today, to simplify things, we will use this International Association of Study of Pain, where CRPS is divided into type 1 and type 2. Type 1 is CRPS without demonstrable nerve damage, which is the most common. And then type 2 is CRPS with evidence of identifiable nerve damage. And normally CRPS type 2, they have minimal positive response with sympathetic block. Okay, pathophysiology-wise, according to papers, it is multifactorial. Okay, so it can be due to inflammatory changes, immunological changes, peripheral sensitization, central sensitization and neuroplasticity, and of course, autonomic changes. So we discuss now on the risk factors. What are the risk factors that can lead to CRPS? The first being obviously the trauma with exaggerated response to injury. It is the most common reason for with poor outcome. Next is of course surgery, and then followed by prolonged immobilization. Anxiety or depression also can lead to CRPS, and the use of ACE inhibitors, and history of migraines or asthma, and of course smoking. Now, let us discuss a bit how ACE inhibitors can cause CRPS. So, for the pathophysiology of it, in healthy skin, okay, when the healthy skin is introduced to triggers like fracture, sprains, or surgery, substance P and bradykinin will be low. So there will be no effect on the ACE inhibitors. So this will lead to the inflammatory response we call as the pre-CRPS. So when this happens, substance P and also the bradykinin, they will increase, but the degradation of the ACE limits the exaggeration of the inflammatory response. So there will be diminished degradation of the substance P and also bradykinin. This will lead to clinical CRPS. And because of this, they will have persistent increase in the substance P and bradykinin, resulting in a flaccid neurogenic inflammation. Okay, now let's discuss on the clinical presentation. So the cardinal signs in CRPS we need to take note is first, exaggerated pain, second, swelling, third, stiffness, and of course, skin discoloration. And on physical examination, we need to look for any vasomotor disturbance, any trophic skin changes due to this, and also any hyperhidrosis, and any flamingo gait for those knee involvement, and any equinovarus deformity in if there's any ankle involvement. For assessment and imaging for radiograph, we will normally find osteopenic changes, soft tissue swelling, and also subperiosteal bone resorption, and presence of diminished joint space. And we can also do 3-phase bone scan and nerve conduction study to study to assess the severity of the nerve damage. Okay, another thing we need to take note in CRPS is the Budapest diagnostic criteria. Okay, it's quite important in this. So first being continuing pain disproportionate to any inciting event. And then second, the second criteria is that they must report at least one symptom in 3 clinical diagnostic criteria or 4 research diagnostic criteria of the following categories. First, the sensory, where they have hyperesthesia or allodynia. Second, vasomotor, where they have temperature or asymmetry, skin color changes, and also sweating asymmetry. And then next is the pseudomotor and edema, changes in the skin. And then motor and trophic changes, where the patient will complain of decreased range of motion and also motor dysfunction, and followed with trophic changes to the hair, skin, and nail. And next, the last one is no other diagnosis better explain the signs and symptoms. Differentials that we must have in mind when we want to diagnose CRPS is a soft tissue infection, malingering, psychiatric disease like the clenched fist syndrome, neuropathic pain, Raynaud disease, yes, Raynaud disease, and also arterial insufficiency. Now we discuss on treatment. Treatment, it is divided into non-operative and also operative. So non-operative physical therapy like gentle physio and pharmacological treatment can be the first line of treatment. Other than that, we also can introduce, we also can administer nerve stimulation, nerve blockade, and also chemical sympathectomy. For operative, you have surgical sympathectomy and also surgical decompression. Prognosis, how is it? It is they typically respond poorly to conservative and surgical treatment, and better prognosis is seen in upper extremity and warm CRPS and also in children. That's all on CRPS. Thank you very much.